Assalamualaikum, good morning. Today we are having an interview with University Malaya Specialist Center regarding pain management. It's a new kind of treatment, specialized treatment in Malaysia, and we are very lucky to have our specialist from UMSC with us today. We have consultant neurosurgery, Dr. Faizal, interventional radiologist, Dr. Nur Shazriman.
Hello.
Or can I call you Dr. Shaz?
Yes.
Okay. And we have anesthesiologist, Prof. Marzida. Pain management. Maybe we start off with the basic. What is actually pain, and what is the connection between pain with our nerve system, with our brain, and also what is chronic pain? What are the differences? Maybe Dr. Faizal can explain to us.
Thank you for having me here. Pain is a abnormal sensation that we can feel whenever that we have a tissue injury. So we can divide pain into two components, which is acute pain and a chronic pain. The difference here is mainly in the timing. So acute pain is the usual sensation that we feel whenever that we have a cut or we hit our toes onto a corner of a table. Then we have acute pain. It occurs suddenly after the injury and lasted minutes to days and sometimes up to weeks, depends on the healing of the tissue. While in chronic pain, usually patients feel the pain more than 3 months, even after the healing process has taken place. So it causes not only physical pain, but they will have associated emotional and behavioral change as an adaptation to this long-standing pain.
Okay, thank you for having me here. When we talk about pain management, it means that basically these are the group of people or the group of physicians, doctors that manage patients with the primary complaint of pain. Now, your question in which that what are the pain, how is pain treated? So there are multiple ways to treat pain. There are the conventional ways, and then there are also the non-conventional ways. So as a whole, there are many ways to treat pain, and as you see here with these 3 different specialists here with different specialties, together we create like a multidisciplinary approach for pain management. And the second question will probably, you were asking about, is it how does an interventional radiology play a role in pain management? So again, as an interventional radiologist, we work in tandem with the general with the other specialists we treat pain. We discuss our cases together, and some of the pain condition actually needs some minimal invasive image guided therapy, which is what interventional radiology is about. So we do things that basically involves small needles with shorter hospital stays.
So traditionally, anesthesiologists look after patient intraoperatively and relieve them from pain and render unconsciousness. But we also look after the patient pain post-operatively. So with the advancements of technology and with the availability of pumps and computerized pumps and whatnot, we also provide patient control anesthesia, where patient can control their pain by using these pumps, and we then will follow them up in the ward. So because of that, our job is not just taking care of pain intraoperatively and postoperatively, but also up in the ward up to 2-3 days until patient is fully comfortable. Apart from that, we have this expertise where we provide neuroaxial blocks such as spinal and epidural anesthesia and analgesia, and we also provide peripheral nerve blocks. And with this expertise, and we eventually find that our niche is in pain management, and we some of us actually move on and learn more about pain medicine, and they also become pain specialists.
We, as a pain specialist, we use the World Health Organization stage of pain management, where the minimum that we can use is the oral analgesic, like paracetamol, and what call it, the non-steroidal anti-inflammatory medication. And then if this doesn't work over a period of time, then we can step up to a stronger medicine, which is the low opioids, like tramadol. And if this also doesn't work, for example, patient had a chronic cancer, then we can step up to the higher dose of opioids, like morphine and so on. So first, all the patients need to be seen by the pain specialist, and then we tailor the medication based on the underlying disease of the patient. So, and we have to take into consideration the physicality of the patient, whether the patient has a chronic renal disease, whether or the patient has cancer, which after the metabolism of the drugs. So we have to tailor the medication to the patient. And where some of us are practicing, we have intervention treatment, like minimally invasive injections or surgery that caters for all these diseases. Maybe the patient will need steroidal injection, maybe, or patient has a high risk of mortality. If the patient going for surgery, then we can offer them minimally invasive therapy like injection or endoscopic spine surgery. It is a valid understanding for the public to aware of all the side effects of the medicine. However, I would suggest that the patient refer to the doctor first before they can take all this medication, and to see whether is there any contraindication to take certain medication or not.
Okay, well, interventional radiology is a subspecialty of radiology in which we meddle into minimal invasive procedures, image-guided procedures. So, right now, the trend or the advancement is rapidly happening in the area of oncology, in which the interventional radiologists actually provide another arm in modern oncological management. And this involves targeted therapy, in which that we actually are able to deliver treatment directly to the source, which is the cancer. So, and we have a lot of patients with cancer coming in with pain. So again, with the help of image-guided procedures, we can deliver precision treatment to the source of the pain. So we do things like, for example, image-guided needle injection of the nerve, and we actually can neutralize the nerve that is causing the pain. And for example, another example would probably be patients with bone pain caused by cancer in the bone. What we can do is we can actually burn the bone tumor, eliminating the pain, and actually strengthen the bone later on or during the procedure by adding in cements, for example. Now, so there are a few more techniques, a few more procedures that we can do, but generally it involves less invasive treatment to the directly targeted to the source of cancer, to the source of pain actually.
The source of
Yeah.
pain. It can be any disease, not necessarily
Yes,
cancer.
it can be any disease that has a focal cause. So with interventional radiology, we tend to target the cause, and we are able to go in directly without having a major operation.
How about lungs? Lungs.
Yes.
Lungs.
Speaking about lungs, we do have the option to actually burn the lung tumors.
Oh,
Yeah.
okay.
So like small tumors, it is now acceptable to actually not go for surgery in certain cases. I'm not saying for all. Okay. There are patients who are not fit for surgery but has a tumor in the lung, which can be controlled by just burning the tumor itself.
How expensive or how affordable actually using a radiology to actually treat cancer cells?
That's an interesting question, because as it is, interventional radiology is still in Malaysia a specialty that is growing. Because of that, the availability itself is limited to a certain big centers. I mean, we have some interventionists from the Ministry of Health, some from the Ministry of Education, like myself, and some also from the specialists, the private side. All in all, there will probably be about 50 odd more of us lying around in this country providing this similar kind of service. It is expensive, yes. I would say probably not too expensive. Yeah, but because we dabble in technology, new things, and new devices, and any new devices will probably cost a little bit more than conventional therapy.
And there are not many specialists around the
Yes.
country.
Actually, that's definitely a myth that anesthetist is not around when the patient is asleep. Because the job of an anesthesiologist is not just putting the patient asleep and render unconsciousness and pain relief, but we also monitor the patient's vital sign, meaning we make sure that that the patient is well asleep, meaning there's no awareness or wake up in the middle of surgery like you said just now. And we monitor their heart rate, their blood pressure, temperature, their fluid balance, yeah, everything. And we also make sure that all their nerves, superficial nerves, are all padded, that they don't have nerve injury after the operation. So basically, when the patient is asleep, the anesthesiologist is the one who's looking after the patient medically, so that the surgeon can continue doing the surgery.
This is a very interesting question. First of all, we have to understand what is the cause of the pain and whether it is necessary to block that pain or not. Take, for example, some pain is very essential. A chest pain that radiates to the left shoulder signifies a heart attack, which if we blocked it, patient might have a silent heart attack. And on the other hand, if we know that the pain on the left, on the chest, is because of entrapment of the nerve to the rib cage, because of maybe the patient had accident before and fractured the rib, then perhaps the blocking that nerve is necessary. So the rule is we must know what caused the pain. And on the topic of electrical stimulation to the skin, that we call it TENS machine that is available in the market, I would say that it is safe to use. However, the patient need to know whether there is a quality control of this machine that is available or not. And it is safe because the electrical current is supplied by a small battery. However, if the patient is diabetic, means that they cannot feel the leg pain, there's a reduction in the sensation of the skin. However, the patient probably have some other pain, radiating pain. I would say I would advise them to use this TENS machine because unsupervised usage of this machine may cause burns on the skin and aggravates the diabetic situation. So the moral here is know what is the cause of the pain so that we can treat them.
Right. So the beauty of medicine and the beauty of science itself is that everything that is unknown, okay, is potentially useful, or everything that is unknown, there's potential, is a potential solution. Okay, so there are many alternative treatments for pain that we can read and we can Google: hypnosis, acupuncture, yoga, exercise, and I am I can happily say that I do not say that these treatments are not useful at all. I mean, in the Western Hemisphere, the Western world, they have already started to accept alternative therapies to pain, and it's already considered, in some regions, is already considered as part of the pain treatment plans. So, yeah, but I would say that the best approach is to not totally rely on the alternative treatment. Rather than take it just as one modality, you must actually try to see whether you can incorporate this in the whole management of your condition. So I would say it's not something ridiculous, it's not something that is not true. There are many known case studies of people benefiting from alternative therapies. But again, maybe not as one treatment only.
So we do have a pain clinic in UMSC, and it's essentially a multidisciplinary kind of pain clinic, which is run by anesthesiologists, neurosurgeon, interventional radiologist, and also rehab physician. And our intention is to provide a holistic pain management. And we are treating the people that can benefit from this treatment include people who are suffering from acute as well as chronic pain. And chronic pain for a long time has not been properly recognized, but with the new publication by WHO on ICD-11, they have included chronic pain as a disease entity, and it can be divided into chronic primary pain and which pain that is, we do not know the reason behind it. This include such as widespread pain, musculoskeletal pain of that is usually termed non-specific, or irritable bowel syndrome, or even headaches that have no underlying cause. So, and we also have chronic secondary pain, which is caused by underlying diseases such as cancer, visceral pain, neuropathic pain that's due to lesion in the somatosensory nervous system. Also pain caused, such as headache and orofacial pain, and a pain due to post-surgical, due to surgery, and pain due to injury or trauma. So these are the types of pain and pain patient that can come to the pain clinic. And in the pain clinic, our services include, apart from medical regime, also include rehabilitation and physical therapy, such as, which include occupational therapy as well. And then all the procedures that can be done by any one of us, which include steroid injections or spinal injections, peripheral nerve blocks, trigger point injections, and also ultrasound treatment. And of course, if we find that there's a need that the patient can improve by going through surgery, then we will refer them to the surgeons. This is such as spinal surgery or joint replacement, joint replacement surgery. And of course, when everything doesn't work, we also include the complementary treatments, such as, like Dr. Shahs have mentioned, you know, like relaxation, hypnosis, acupuncture, and massage, and the use of TENS, but all this complementary medicine can help, but the problem with it is the result is not consistent. So that's why it's always have to be done together with conventional pain management. Yeah. So with this ICD-11, the new ICD-11 by WHO has sort of recognized the existence of chronic pain, and hopefully this will increase the access of patients with chronic pain to actually receive treatment from pain clinic.